Hi, this is Dr. Roger Yang. Now about to show you a case of breast malignancy that the traditional CAD actually did not flag. All right, so our viewing protocol on our third-party vendor packs, we're looking at a mammogram, screening mammograms with priors. We've already been on the work list. The work list had flagged this case, told the radiologist, the human reader, that there's something here that we need to pay attention to. And already with the four views that you see, the two current on the bottom, the two priors on the top, we're already getting the sense that there's something going to be developing in that left central aspect of the MLO view that we're going to be worried about. Okay. And indeed, when we toggle the artificial intelligence on, you can see that it's marked that area, contralateral breast. There are some calcifications that we're going to pay attention to in a moment. All right. So we're going to now zoom in and go to high fidelity on that left MLO view. We're going to toggle off the AI. We're now going to go over to the tomosynthesis. As per training, we're going to now go through in this case, 74 slices where we're going to analyze the glandular tissue. We already see numerous calcifications. I've left the annotation on where we flag the irregular mass in this breast. So now we're going to use the artificial intelligence markers. You can see here that it's worried about a skin fold back over here. That overall suspicion score of 10 out of 10 is from the other area. This density of 46 is actually a relatively low mark. The AI wanted us to pay attention to it, but it's not given it a very high marker here. In comparison, out of a score of 99, the AI is given this region a 94. So this is something that the AI is very worried about. And when we toggle the artificial intelligence off, indeed, as we pan through this area, you can see that there is an irregular spiculated mass. And for us already, and this is the screening mammogram, for us already, we know that we're going to be calling this patient pack for additional views, ultrasound, and potentially eventually biopsy. And when we compare this to the priors, we can see that in this region, there's nothing else going on there on the priors. Now, when we go back to that left MLO view, the curious part of this case is that to the human reader and to the artificial intelligence, this is something that clearly is going to end up being abnormal, something that we have to call back and further analyze. Now, here's the AI marks again, and I'm going to turn the traditional computer-aided diagnosis. And you can see that the traditional CAD has placed triangle markers in areas of calcification separate from the areas of calcifications on this breast. And so this is something that ends up being interesting, that for whatever reason, the CAD is not identifying this irregular mass that we can clearly see. So that's that left MLO view. Here is the left CC view. And I'll bring this up again. We can see that the artificial intelligence does not like the area of what ends up being a malignancy. Okay, this was biopsy proven. And when we put on the computer-aided diagnosis, it's actually worried about something in the lateral aspect of that left breast. You know, part of these vascular calcifications and maybe some punctate calcifications are over there. So this is a curious case where the findings were straightforward for the human reader, straightforward for the artificial intelligence, yet the traditional computer-aided diagnosis, for some reason, did not flag this irregular mass. Actually, was worried about something somewhere else that ended up being benign, and looking benign and being stable. So in the end, this patient underwent additional views, biopsy proven malignancy, underwent treatment, and is now going to be annually followed after lumpectomy after treatment. Hi there, Dr. Roger Yang, now showing you mammography of ductal carcinoma site 2, diagnosed with calcification seen on the mammogram and the aid of artificial intelligence. Okay, presented before you are the usual screening mammography protocol. We have the current studies below, and these are the MLO views and the prior studies above. What we already know from the work list is that the artificial intelligence is worried about this mammogram. It's telling us to pay attention, and you can see with the blue marks highlighted here on this right MLO view, nothing on the left-hand side, that there's something on the right that we need to pay attention to. When we toggle on the artificial intelligence, that diamond marker denotes to us, the radiologist, that there are some calcifications at this site that we need to be worried about. And so we're just going to zoom in and go to high def on that site. We're going to toggle off that AI marker. And we can indeed see that within this region, and I'm going to zoom in for now. Within this region, there are some calcifications that I'll tell you also, when compared to the prior studies, are new. So we've got some pleomorphic calcifications, different sizes and shapes, maybe even some linear ones right adjacent to it, that the AI is telling us to pay attention to. The calcifications, obviously, as you guys are all trained to know, on these C views, certain vendors on C views will make calcification stand out even more. And so we are trained to then go to tomosynthesis. We'll pan through. We're obviously looking in the other sites of breast tissue as well, making sure that within these areas of scattered fibroglandular density, that there's no spiculated mass, distortion, or anything else to worry about. There are other benign calcifications that we're seeing elsewhere. And we're already getting the sense, and I'll begin to pause in the area where the calcifications live. We're beginning to get the sense right in here that there are some calcifications that even without the AI, the human reader is worried about. You see the clustering. You're beginning to see maybe even a little bit of a lambda there. You know, these calcifications, we hope none of us would ever miss. Here's some right adjacent to it, some other pleomorphic calcifications that are developing in this right breast. Now, using AI, we use the tool to toggle directly to the area. You can see that the AI has placed this diamond marker. It is the area that we're worried about. It is this particular cluster or this particular section of the calcifications within this region that the AI is worried about. And indeed, we called this back for additional views, magnification views, and this ended up being ductal carcinoma in situ. Okay, now, some of the teaching points on this particular case is, and we're going to go back to the C view, is that once again, we can clearly see the calcifications toggling on the CAD, the traditional CAD. You can see the CAD did not miss it either. I mean, here are the calcifications, and the CAD felt it was as well a place to pay attention to. This area of asymmetry is stable. I want to go to the right CC view, and I want to show you, and here the CAD is off. We're going to turn on the artificial intelligence. The AI is marking this area, okay, with the calcifications clusters, and that's the area of DCIS. I'll mag to that area. And you can see that there are some extensive calcifications in there. Panning through on the CC view. No other suspicious finding. Getting to the calcifications. There's some dense tissue here. You can begin to see the tomosynthesis analysis of the calcifications. We were worried a little bit about some distortion in this area. Is there actually an invasive in there? It turned out not to be, but still something you can see panning through on the tomosynthesis. Maybe there's distortion there, and the AI did not pick that up. And in the end, it did not end up being something suspicious. And here is the analysis with the AI. Okay, now, after all of that, one of the things I wanted to show was that there's the AI analysis. And at the end of the case, as we're all trained to do, we turn on the traditional CAD in order to make sure we didn't miss anything. And you can see the CAD is placing asterisks on these areas of density. And on this CC view, it did not actually pick up these calcifications, which is interesting. You would think, perhaps that with the algorithm trained to the CAD, that clustered calcifications like this would have been marked with that triangle marker that CAD usually marks with. But in this particular case, the AI found the region we needed to pay attention to. The CAD, the traditional CAD, did not. Now, the traditional CAD did do a good job on that right MLO view. All right, so it did mark the site anyway. So I'm not sure that there was any lack here in terms of the CAD, but certainly the AI was a little bit more functional in this area, making sure the radiologist paid attention to this area of DCIS. Patient went on for treatment and is now being monitored annually. Hi there, Dr. Roger Yang, now showing you a case of breast cancer, some vascular calcifications, and how the mammography artificial intelligence dealt with them. So we were on our work list, and this case was flagged with AI triage as being something to pay attention to. The artificial intelligence is worried about this case. And indeed, when we pull up the mammograms, and before you right now are the two MLO views. We don't have the prior studies at this point, and so we're looking at this mammogram thinking, wow, I'm seeing something here on the left side, and it is something that we need to worry about. For the short term, I'm going to be pulling down the CC view, and you can see that already this is something from a gestalt standpoint that we're already trained, and with experienced radiologists, we're already trained to say this is going to be something that's worrisome, and we're going to have to move on to biopsy probably at some point. But for now, on the screening study, we're already seeing something that we're going to call back, that there's a mass on this left side. Okay, now, when we look at our AI, once again, on this dense-breasted patient, we're toggling the AI on, and we're beginning to see that there's some triangle markers in other sites. And we all want to make sure there's no multifocal disease when we see a BI-RADS 5 lesion like this. And again, I'm getting a little ahead of myself. We know this is the screening mammogram. So all we're kind of being asked to do right now is to decide whether or not to call this patient back. Is she a BI-RADS 0 or is she a BI-RADS 1 or 2? Okay, so getting ahead of ourselves, we know that with a lesion like this, it's important for us as radiologists on the screening board to make sure there are no other areas that we are worried about. And so the artificial intelligence is theoretically supposed to help us find these other areas. So let's go through this and go to high def with that left MLO view on the ipsilateral side of the finding that we're already worried about, that the AI is already worried about. We're going to toggle the AI off. And as we analyze this, we definitely see that dominant mass, and we see other punctate calcifications within the breast. We're seeing the vascular calcifications within the breast. And so we'll toggle on to tomosynthesis. And I'm just panning through, and you already saw that I left the radiologist's mark here, finding that mass in that left breast. So on this particular case, unfortunately, that's not the hard part. So once we're satisfied and through with our analysis as the human reader with the concurrent AI read, we now will toggle to the areas that the AI is worried about. And so we obviously see that mass that has the highest AI score, 10 out of 10 in this particular vendor. The region analysis for this breast density is an 87. We toggle to the next spot, and you can see that the AI is actually very worried about that. And that has a region analysis of 76. Okay, so it's a fairly high analysis. And when we toggle that AI off, we can see that classic sort of train tracking of calcifications. I'm going to magnify that. And you'll see this classic look. It's actually relatively easy for the train rad because this is a continuity of this serpiginous density with other things leading up from the axilla. These are clearly arterial vascular calcifications. And in this particular case, the AI really was worried that perhaps there was some DCIS in this position, and actually there's not. I don't want to skimp on this particular case. There are definitely other findings that were eventually evaluated and biopsied. You can see that there's probably potentially a second mass over here, and other areas of density that one would eventually recommend MRI for. So this is not something that's as simplistic as a single focus lesion. What I'm trying to show here is that the artificial intelligence often can be led astray with some findings that might mimic malignancy. In this particular case, linear irregular calcifications that are, to us, probably clear to be vascular, and to the AI, not so clear. Going to the contralateral breast, once again, we're trying to rule out multifocal disease, and we are seeing that the AI does not like two areas of calcifications here. We're going to go into tomo, evaluate the 73 slices, make sure there are no other masses, architectural distortion, other things that we worry about is invasive malignancy. And as you saw blipping in and out, and I'm now going to toggle and use the AI tools to go straight to the area that's abnormal. Once again, the artificial intelligence is worried about that spot. I'm just going to zoom in, and you can see that these, once again, have that train track or tram track calcifications lining up with each other, associated, luckily, with a very easy to identify serpiginous density. The rad is able to toggle in and out, and we can see that we believe that this is going to be vascular calcifications. Then we're going to go to the next site, and the AI is worried about yet another area along this same artery with the atherosclerotic disease, another area that we should pay attention to. So the artificial intelligence is not meant to be the magic replacement of the human reader. There's definitely things that the human has to weigh in on. The AI tools that I'm aware of still do not take into account priors. Okay, so often with these cases, what you're seeing is a new baseline every time analysis. That CAD as well, we're used to the traditional CAD doing that, and we should get used to artificial intelligence for the short term, maybe even the intermediate term. It's still not doing what we do as humans, which is to compare to the prior studies, to take the clinical history into account, all these different things. Okay, so I think we're far shot away from having any real replacement of the humans with artificial intelligence. In this case, this is a malignancy clearly in the left breast, but you can see that the artificial intelligence is marking areas that the human being would probably actually say, yeah, that's not a big deal. That's just atherosclerotic disease, which of course is a big deal to the patient perhaps, but on the mammogram, it's not a multifocal disease. It's not a malignancy. Okay, now when you toggle on the CAD, you can see the markers, the triangle marker on the vascular calcifications, the asterisk over here. This lines up actually very well with what the computer-aided diagnosis is trying to do. So in this particular case, where it's a BI-RADS 0 mammogram that eventually led to biopsy and diagnosis of malignancy, and then treatment subsequently, you can see that the artificial intelligence and the computer-aided diagnosis actually line up very well on this one image, and that certainly none of us would biopsy the vascular calcifications, but certainly the two computer protocols were correct on the main mass on that left breast. Hi all, Dr. Roger Yang, now showing you a case of architectural distortion that ended up being a malignancy, the mammography artificial intelligence helping the radiologist make the diagnosis. So we were on the work list before. The radiologist has seen that here's a case that the artificial intelligence is worried about. You're launching the case. We're seeing in our usual viewing protocol, prior studies on the top, current studies on the bottom. You're presented right now the bilateral MLO views. You're seeing dense tissue. The mammogram already had the artificial intelligence analyze it. And when we toggle that on, you can see that on the left side, there's a diamond marker where there are some calcifications we have to pay attention to, and there's an architectural distortion. On the right, on the MLO view, there are two areas where the artificial intelligence are marking calcifications, again with the diamonds. So let's go straight to the area of abnormality. We're going to go into high fidelity on the MLO view. Turning off the artificial intelligence for now, we can see that over here, there is some density and there's an architectural distortion in the area of concern. As we go through that, we also see that the area of calcifications already has the impression of some clustered ground calcifications, that superior aspect of the left MLO view. As we usually do, we'll now go into the tomosynthesis. We'll now pan through the area. And as we get the gestalt of this, we are indeed seeing that there is an area of distortion, more clearly seen with an area of density and mass-like density with the tomosynthesis views. Turning on the AI, hovering over it, you can see a high region analysis of 92, leading to that overall score, 10 out of 10. This is an area that the radiologist really has to pay attention to. The calcifications, that region analysis is more moderate at 58. And so the overall score is still 10, with that contributory from the actual architectural distortion and mass. That's highly suspicious. We're now going to go into the contralateral breast. Here's the artificial intelligence again, marking two areas of calcifications that we're worried about. Toggling that off, we can see once again that in a backdrop of many calcifications, that these are clustered, potentially round calcifications going into the tomosynthesis to make sure that there's nothing else that we're missing here. We're seeing a lot of complex tissue, lots of calcifications, nothing particularly suspicious at this point. Let's toggle straight to the areas of abnormality with the AI. We see the calcifications here, score of 74. Another set, score of 56, and the other calcifications are not marked. So this pattern here, and in this particular case, on this left side, this was a malignancy. Biopsies were performed of the calcifications at these other sites as well, and they turned out to be proliferative fibrocystic changes with benign results there, benign and concordant, and those will be followed. So in this particular case, what I'm showing you is an area of architectural distortion that turned out to be a mass on the tomosynthesis, and the artificial intelligence correctly flagged it. Turning on the computer-aided diagnosis, you can see the CAD, the traditional CAD, would also have helped make this diagnosis as well. It does flag multiple of these calcifications. It does flag the main malignancy we see on the left. One of the points here is that as we look at that right MLO view where we did biopsies of these regions of calcifications, you can see that the traditional CAD has marked it at the two sites, and it's actually remarkably similar to the artificial intelligence. So in this particular case, the AI and the traditional CAD are somewhat lined up, and the radiologist also believed it and was lined up as well here to call this suspicious, and this underwent biopsy. It happened to be benign results, but the right call was made. Given the contralateral cancer, we want to make sure there's no multifocal disease. So this patient underwent treatment on the left and will be followed on both sides with the routine follow-up mammography after breast cancer therapy. Hi, it's Dr. Roger Yang, now showing you a case of malignancy diagnosed with the help of artificial intelligence. So before you, once again, is our standard reading protocol for screening mammograms. On the bottom are the current studies, on the top are the prior examinations. Now, as we've gone through before, we read off the work list, and on the work list, this is already flagged as something that the artificial intelligence was worried about. So we go into this case with some knowledge that there's something here that the AI wants us to pay attention to. As we look at the case, after looking thousands, tens of thousands, hundreds of thousands of mammograms, as well as many thousands of cases with the artificial intelligence, we already get the sense that this is not going to be your typical lumpectomy site or something obvious that's being picked out by the AI. You can see that on the MLO views, there's some mildly dense tissue, calcifications, things like that, that pretty much match up to the prior examinations above. So with the help of the artificial intelligence, we'll go to the left MLO first. We toggle that on, and we can see that it's worried about something here on the left MLO view in the inferior aspect, and on the right side, calcifications in that parareolar position. Okay, so we will now zoom in or go into high fidelity on the left MLO view. The CAD is still on. I'll toggle that off for now. We'll go into the tomosynthesis, and we can see with the scattered fibroglandular densities, lots of calcifications. And as we pan in and out, and I've pre-marked this so you can see where we, the radiologist, felt there was something here, we're seeing an irregular nodule. Okay, now when I toggle off the tomosynthesis, you can see on the 2D C view, there's some superimposed glandular tissue here. So the DBT very much helps in this particular case because this area is not so evident on that 2D view. I'm going to pull up into high def the prior left MLO view. And if you imagine with me, maybe there was some density there, or is that just the superimposed glandular tissue? Back to our current case, going back to the tomosynthesis. So in this particular case, we're going to go to the artificial intelligence. We'll hover over the site, and you can see it's giving it its highest score, 10 out of 10. And that breast density region analysis of 79 is also very high. And so the AI is worried about this site over here. So this ended up being an infiltrating ductal carcinoma. And I think in this particular case, you can see how the AI got it right. And I think that the radiologist might have a chance of missing that. The tomosynthesis, probably not. It was fairly evident on the tomosynthesis, and it was definitely something that in the end, retrospectively in particular, you can say, yeah, there's definitely something growing in that spot. Now, I'm going to toggle on, as we do at the end of each of these cases, I'm going to toggle on that traditional CAD. And so you can see that the CAD actually cleared this mammogram. CAD successful with no findings. And so toggling that on and off, the CAD, the traditional CAD, would not have flagged this site for us, the human reader, on the mammogram at the end. So if the radiologist had gone through the case and not noted this dense tissue, used the traditional CAD, and saw that the CAD liked it as well, there was a chance that perhaps they would miss something here and have missed this small developing cancer. Okay. Now, with the artificial intelligence, knowing beforehand that we had to be careful with this case, or more careful than other cases, and going through our analysis and not having the AI help us get directly to the area, there was very little chance that the radiologist would have missed this cancer. We're going to go to the other side, and I'll show you on the flip that the artificial intelligence is worried in this diamond marker here that there's some calcium deposits that it might be worried about. Now, in this particular case, we go to the tomosynthesis on the right MLO view. We are now tomoing through the mammogram pictures. And when we use the artificial intelligence analysis and it toggles us to the site that it's worried about, we see that diamond marker, we toggle that off. And here, as one of the pitfalls of artificial intelligence, is sometimes you can see in this case, in the left MLO view, the contralateral left MLO view, the tomosynthesis image that the AI flagged for us, the artificial intelligence got it right. On this other side, I particularly do not think that this is actually clustered calcifications. As I pan back and forth through this area of tissue, you can see a semicircular area of breast tissue density that I'm panning in and out of. And so although the artificial intelligence was right on the other side, this area here, I think we can pretty much ignore, even though that it still has a sort of a moderate score for the artificial intelligence of 57 in this area. It still carries with it that high level overall score of 10. This is not an area that's suspicious. This looks like a patch of tissue. It looks stable from the priors. And I think we can just follow that annually. And of course, this patient went forward, got biopsied in the area that we were worried about, and that ended up being cancer. So this was a case of the artificial intelligence being correct, the traditional computer-aided diagnosis being incorrect, and the human reader being aided anyway, and therefore making the right diagnosis. Hi, everybody. Dr. Roger Yang, now showing you a case of biopsy-proven papilloma after the screening mammogram. In this particular case, this is a patient who's had multiple previous other biopsies with benign results. She presents to us for a new baseline. The prior studies are not available to us. So on the work list, on this particular case, we already saw that the artificial intelligence felt that there was a higher than average chance that this case had a malignancy. It was rated 9 out of 10. And so we go into the case knowing that there are findings here that we need to pay attention to. Presented to you are the 2 MLO views. We did not have the prior views, so those are not presented above. When you take a look at the artificial intelligence and toggle them on, you can see on the left at the inferior aspect and on the right at the upper aspect, there are findings there that we are going to have to pay attention to. We'll turn this off for now. We're going to go into high resolution for the right MLO view. So looking at the dense breast here, you can see that the surgical scar has been marked in the inferior aspect of the breast, a biopsy clip from previous biopsy at a different site at the posterior depth of that right MLO view. So as we pan through the breast tissue here, you see the dense tissue, you can see lots of complexity. And we already have the sense that with the previous biopsies that there may be some proliferative changes here that we may end up having to pay attention to. We toggle the artificial intelligence and tell it to go to the site it's most worried about. And it shows that large, relatively large nodule. Hovering over it, we can see the score 9, which the maximum score is 10. and this density is marked 56 in its region, once again, suggesting that there's something here to pay attention to. This is a baseline study, so we're not able to compare this nodule to any prior. It's large, and therefore this was called back. It proceeded to have biopsy, and there was a papilloma in this area. The papilloma was within a cyst. It actually was a complex cyst, and the papilloma was in the periphery and ended up being excised. So this is a case of the artificial intelligence discovering an atypical lesion and marking it correctly, having the radiologist pay attention to the site that had the papilloma. Now, when we then compare to the traditional CAD, you'll see that the traditional computer-aided detection had no findings on this view. And so this is one of the differences between the old traditional computer-aided diagnosis and the current artificial intelligence. Previously, we told the computer and the CAD algorithms what to look for. So when we say to a computer-aided detection algorithm, look for irregular edges, look for this, look for that, look for density, etc., it'll follow the programmer's instructions and mark things that the programmer feels need to be marked. Artificial intelligence, especially with the learning that it does, with the convolutional neural network, what ends up happening is that we sometimes can't put our finger as to why the AI felt that an area was suspicious or not, but when it learns from all of these cases, tens of thousands of mammograms that is analyzed, and it decides when it's fed the ground truth of there being a cancer there, the AI has a deeper layer of analysis, and for whatever reason, it felt this was suspicious, and for whatever reason, the CAD did not mark it at all. Now, again, in the end, this was a papilloma, perhaps could have been followed, but it is good to know in this patient that there was an atypical, potentially suspicious finding here for us to biopsy and eventually remove. There is some thought that there are some upgrades of papillomas during excisional biopsy. Certain percentage of these actually are low-grade cancers or associated with adjacent other cancers and a marker for tumor. In the end, this ended up being a recall, ended up being a papilloma, and I think that the artificial intelligence very much helped to steer the radiologist to calling this area suspicious. Hi there, Dr. Roger Yang, now showing you mammography artificial intelligence in a case with biopsy-proven fibroadenoma. So I'm presenting to you a patient who came to us many years after multiple biopsies for fibroadenoma. We actually do not have her prior films as they were done in a different state, and she presented to us as a baseline study. She presented as screening because they knew historically that there were benign biopsies and there were no new symptoms. Presented before you are the two MLO views. Viewing protocol, there are no prior examinations. We already knew beforehand that the artificial intelligence felt that this was the highest score, meaning that it is worried that perhaps there's malignancies here. So when we take a look, you can see the artificial intelligence on the left MLO has this highlighted blue. On the right MLO, the artificial intelligence is okay with that view. I'm going to pull in the left CC so that we can see that both the CC and MLO on the left have something that the artificial intelligence is worried about. So in summary, when we hit and toggle the artificial intelligence here, you'll see that first it highlights one of the three masses that you see with clips already on this 2DC view, two, and then that's the summary on the CC view. Similarly, one, the second one, and two. Okay, now interestingly, the artificial intelligence is internally consistent. It's these two masses in the medial and more posterior breast that it does not like. Let's go into the high-res pictures here. We have the 2DC view. I'm going to toggle off the AI. And here's the mammogram. And to the radiologist, we're seeing already dense breasts, three masses, and three clips. Put together with the history, we're kind of prepared for looking at these and saying that these are likely benign, previously biopsied type lesions. And with the history of fibroadenoma, that's actually what it looks like. We'll toggle the tomosynthesis on. And as we always do, we pan through the cases. As we always do, we pan through the slices, and you can see that there's a lot of dense tissue. The three dominant masses on the left have biopsy clips. There's a suggestion of potentially other small masses, such as this here, but this looks very similar to the already biopsied larger lesions. And with the multiplicity and the benign features, overall, the pattern does look benign and consistent with the patient's history. Going to the tomosynthesis, toggling it on and off, that more posterior mass, once again, you can see the AI score, its highest score of 10 and the region score of 55. Using the AI tools to toggle to the next lesion, hovering over it, once again, scored 10, region analysis of 53. So in many instances, at this point, if there were not biopsy clips and you had not previously biopsied this, potentially the radiologist would align, and in fact, the radiologist previously aligned with the artificial intelligence and said, okay, these are dominant masses. We need to know what they are before we let this patient go to routine screening. And indeed, they biopsied 3 of these lesions and they all came back fibroadenoma. So at the time of the analysis, this artificial intelligence is correct. These are things that the radiologists are also considering suspicious. It just so happens that we already have the biopsy results on this. And when you analyze this, this ends up being a BI-RADS 2. Now, the other interesting thing is at the end of the exam, after the AI analysis, we're taught to use the traditional CAD as the tap on the shoulder to evaluate the case, make sure we have not missed anything. And when I toggle that on, you can see that the asterisk denoting suspicious masses for CAD agrees with the AI and the MLO view and does not exactly agree with the AI on the CC view and is marking the lesion that is in the lateral aspect of that left CC view. Okay, so overall, that previous radiologist who likely recommended biopsy of all 3 of these lesions, both computer sets in different ways, eventually agrees with the RAD. In the end, you can see that AI and CAD do slightly different things, just slightly different analysis. And you can see that fibroadenomas that were previously biopsied sometimes come up as suspicious to the artificial intelligence as well as the CAD. In this particular case, given the history, given what we know about the AI and CAD, this was called BI-RADS 2. Patient is asymptomatic, and we will check her again in another year. Hi, everyone. Dr. Roger Yang, now showing you a lumpectomy site on a screening mammogram. Obviously, we all feel that with the architectural distortion, post-surgical changes, all the different post-treatment findings that we see on these lumpectomy sites, we'll often find the traditional CAD marking these as suspicious. And of course, we do expect the artificial intelligence to do the same. So as before, we're starting with the work list. We're looking at this patient's cases, and we see that the artificial intelligence with AI status is on, and the triage is red, meaning that maybe there's something that we need to worry about on this mammogram. So as we take a look at that, we can see that this particular artificial intelligence has given it the highest suspicious score at 10. And both of these little images show that there's maybe something here on the left side. So as we can see here, this is our usual viewing protocol for looking at the mammograms. This is a screening case in a patient who's had previous breast cancer and has undergone conservation therapy and lumpectomy on the left. The current studies are on the bottom, the prior studies are on the top. We can pan through some of the prior exams. And we already know from the work list that the artificial intelligence feels that there's a finding that's very suspicious here, suspicious to the AI. And when we toggle that on, indeed, what we're seeing is that it's looking at that lumpectomy site, which with the characteristics of architectural distortion, irregularity, and some mass-like density, this is, of course, something that we would expect a artificial intelligence or CAD without the priors to mark as being something that it's worried about. As we always do, we go to the main image. We look at that in real high fidelity. So as we're now analyzing this, we see on the CE view, the 2D view, the lumpectomy site, a benign appearing nodule at a different site on this MLO, some scattered calcifications. You go into the tomosynthesis views. pan through the 57 slices in this particular case, make sure there's no underlying other lesion. Functionality-wise, we use the AI to go to the site that it's worried about. So we've toggled that on. We can toggle it off in order to analyze the underlying characteristics. Toggling it back on, hovering over the marker, you can see what the computer thinks. So this artificial intelligence has given this its highest score of 10. And in that region, there's a 67 score, which suggests it's something that it's worried about. Now for us, we've shown stability of this lesion when comparing it to the priors, and we've shown that there's another lesion that is in the posterior aspect of the breast with some fatty characteristics, and this may be a lymph node in the medial aspect of that breast. Lastly, as we're all trained to do, the CAD, the traditional CAD comes last, and then when you toggle that on, you can see that this actually had no findings for the CAD because this is a dense breast, and a lot of the lumpectomy findings were not evident on the 2D view or not as conspicuous as the traditional CAD wanted to see. It was the tomosynthesis analysis that led to the artificial intelligence to have a better look at that architectural distortion and surgical scar site. In the end, given the stability and given what we know about this patient historically, this was assessed as BI-RADS 2, and this lady will also be followed annually with screening mammograms. Hi, Dr. Roger Yang, now showing a case of a complex glandular pattern, complex calcifications pattern that fooled the AI and the computer-aided diagnosis. So I'm skipping the work list to go directly into the mammogram in this case. You're seeing once again the MLOs laid out, current on the bottom, priors on the top, very dense breast tissue. And you can see even from these minimized views that there's a lot of calcifications in both breasts. From the work list, the radiologist already knew that the artificial intelligence thought that there was a high probability of cancers in this mammogram. When we looked at the artificial intelligence markings, we showed these triangle markers showing the AI thinking that there are calcifications in multiple areas of both breasts. The CC views are very similar. We're going to blow up one of these, and as you can see on the standard C view with the AI on, the triangle markers are worried about two particular areas. In this particular artificial intelligence, when we analyze the tomosynthesis, here's the C view 2D. Here's the tomosynthesis, and as all of us are used to, we are now scrolling through the slices on the DBT. Now, in this particular case with two findings, we shortcut over to the abnormalities that the AI is worried about. We can see that right over here, there's a calcification cluster overlying the pectoralis muscle. Those are the scores that the AI is worried about. Once again, thinking that this particular area is an area to be paid attention to. Toggling things off, you can indeed see a few calcifications in this area. The AI can then toggle to the next area that it's worried about. And the human analysis can say, yes, indeed, there are calcifications in this area. Now, in this particular case, these calcifications are actually stable from the prior mammography. You can see in the backdrop of this tomosynthesis, there are multiple areas of clustered calcifications that we often see in these complex fibrocystic cases. This does not mean we should not pay attention to the AI markers. We really should take a look at those areas where the AI is worried, make sure that we are convinced that they are stable, that we are convinced that these calcifications look similar to the others on the mammogram. You can see also through the tomosynthesis that there is a suggestion of fibrocystic changes within the dense tissue of this breast. And so this ends up being one of those BI-RADS 2 benign findings where you're seeing and tracking multiple cysts, multiple benign appearing calcifications with stability when we track it to the prior mammography. Certainly, if some of these calcifications, such as this cluster here, are those marked by the AI, and functionality-wise, I can go to the left side of the screen and we can select the slice that the AI is worried about, toggle the AI on and off. And when off, we can analyze the underlying calcifications. And to my eye, when we look at these clustered calcifications, they are similar to other clusters of calcifications on this mammogram. Now, on a final note, I'm going to display the CAD, which we usually use as the tap on the shoulder at the end of the case. So with the traditional computer-aided diagnosis, we can see that the CAD as well thought there were some calcifications that we had to pay attention to. And when we blow that up, toggling the CAD on and off, you can see that this too selected one of many multiple calcifications that they thought that we should pay attention to as a human reader. How does the CAD compare to the AI? So in this particular case, we often will hear that the artificial intelligence is more specific about the sites that it wants to label, meaning in general, we should have fewer marks with artificial intelligence than with the traditional computer-aided diagnosis. So when we overlay it, we can see in this particular mammogram, this CAD is worried about one area over here. This AI CAD is worried about two other areas on this MLO in two different spots. Okay, so we're left as a human reader with making sure that we have evaluated these sites, that we think that things are stable, that we've tomoed through them, and that we are satisfied that there's no developing malignancy on this mammogram. Now, in general, there are some studies that suggest that artificial intelligence might add time to case analysis. In this particular case, you can see why in certain studies that might be the case. There are many marks that we have to pay attention to as a human reader, and many sites that we already worry about, given that all of us are paying a lot of attention to the calcifications, the focal asymmetries, and all the different findings on this tomosynthesis as I pan through. So this ends up being a complex case from step one. We already knew that when we looked at the four-view current and prior display. We can see that with the traditional computer-aided diagnosis on the prior, that was even more worried with 3 marks on the right MLO, 4 marks on the left MLO, and only 1 on each of these today. So overall, this case might take a little bit more time, but it was always going to take the human reader a lot of time to carefully go through all the focal asymmetries and calcifications over here. Overall, once we're satisfied that we've paid attention to the marks, even though the artificial intelligence thought that there was a higher probability of having a malignancy on this mammogram, we can show stability, multiplicity of these benign findings. And this was called BI-RADS2 to be annually followed with screening mammography. Hi, everybody, Dr. Roger Yang, showing you another normal case, this time in a fatty breast using traditional CAD, artificial intelligence. Here we are on the anonymized Worklist. We have the patient screening mammogram at the top. And as we showed you with the Worklist displays, we use these CAD markers to show us, concurrent with the reads, what the artificial intelligence thinks about the mammogram. When we select that, we can see there's a lack of findings, and that score of 1 shows that the artificial intelligence thinks that there's very low chance of having a malignancy on this mammogram. So on this mammogram, you can see with the current ones on the bottom, priors on the top, these are the MLO views. There's predominantly fatty breast tissue in this one, little areas of scattered focal asymmetry in the perirular positions. When reading the case, we go into the real-time analysis again. We first show the C views, the 2D views. We go to the tomosynthesis. We already know the AI button, which is dark here, that the artificial intelligence feels that there's no findings on their end. On our end, as we're analyzing this, scrolling through the slices, the human reader also feels there's no abnormalities. Those focal asymmetries, we will track to the priors. Some prior studies going through it, and you can see in that perirular position, this is some fatty tissue, and there's some focal asymmetries here. We happen to come across a 2D mammogram that's older over here, also showing those stable focal asymmetries in the perirular position. Lastly, as we're trained, we add the CAD on at the end, and you can see that it says the study has CAD successful with no findings. This is another case of a normal mammogram, but in this particular case, it's fatty with areas of focal asymmetry on the breast. Normal mammogram with a normal AI analysis, a normal CAD and traditional CAD analysis, and a normal analysis by the human reader. Hi, everybody. Dr. Roger Yang, going through mammography, artificial intelligence. This case that I'm about to show you is a normal dense-breasted mammogram. As you can see on this particular work list, this is actually on an individual patient and the exams that they had done. The mammograms at the top, you can see that the AI has a check mark and it's ready to go. The triage function here does not have the red dot, and we take a look at this. And this is a low score, and you can see here it's a low score, not a lot of findings, transparent score 1. So as you can see on this mammogram, we've got current on the bottom, priors on the top. This is an extremely dense mammography. This happens to be somebody who is known to the practice and actually had 3 sets of radiologists reviewing the case. In this particular case, you saw that the artificial intelligence had rated it a 1, and so this is a very low suspicion of having malignancy on it. One radiologist, knowing who the person was, actually thought that there needed to be a recall of some dense tissue over here on the right side. We'll pan in on that. You can see some focal tissue over here. And once again, with the contemporaneous read of the AI, we already knew that the artificial intelligence felt that this had a very low probability of having a malignancy. As we go through the usual process of looking at the mammogram, and we'll stick with this right MLO for now, given that the initial radiologist thought maybe there was a finding here. We go to the tomosynthesis as we usually do. We pan through the 47 slices that this tomosynthesis has. And you can see indeed, perhaps there's a little bit of focal asymmetry in the superior aspect of this right MLO view. Now, the other 2 radiologists who reviewed this felt this was just stable focal asymmetry that was seen on prior examinations. As we know, the artificial intelligence also thought it was normal. And as a last step, we apply the traditional CAD on it. And with that computer-aided detection up here, this is CAD successful with no findings. We find in this particular case with dense breasts that 2 radiologists out of 3, the artificial intelligence and the traditional computer-aided diagnosis, felt that this was normal. And this was given a BI-RADS 1 to be followed annually with screening mammography. This is a case that shows you the relatively uncommon situation where there are many negative or normal interpretations from the artificial intelligence, traditional CAD, and radiologists. Hi, everyone. This is Dr. Roger Yang, reporting to you from New Jersey here, and we're talking about mammography artificial intelligence on a work list using triage function. And so we're going to go through how we use the triage function for mammography. So before you right now is the contemporaneous real-life, real-time work list that we use here at University Radiology Group when we're reading mammograms. You can see the mammograms dated in order from January, some of these waiting for old films, and others in late January into early February. This list is the list of cases that need radiology interpretation. The mammography artificial intelligence evaluates the mammograms by low to high tiered probabilities of having cancer within them. You can see on the left side of the list, the AI status with the check marks on the cases that it's already interpreted, the AI is already interpreted, and next to it, red marks where there are some worrisome findings, no marks where there are no worrisome findings. So here in this instance, we have these by order of date. We here at URG read these cases in order of date as long as they're ready. We're not looking to triage the cases and group them together, but other practices and certainly the Europeans are beginning to look at this triage function to see whether or not it can be used to help them with efficiency. For example, if you triage the cases and pick out a list of cases, as I'm doing right now, where it is laden with high probability of malignancy cases, these cases might, for example, go in a batch where the radiologist is prepared for high probability cancers. In Europe, where they have a double reader screening program, these cases probably deserve 2 human readers to interpret them, given the artificial intelligence feels there may be something here. On the other hand, when you look at a list of cases, and I'll leave some of the marks down at the bottom so you can see that the artificial intelligence is saying that these cases at the top of the list, they're low probability for malignancy. These cases here in Europe potentially may only need 1 human reader, and this is something that the Europeans are currently studying. Here in the United States, we do not have that requirement for all the screening mammograms to have 2 human readers. So for us, perhaps we would batch all these cases in a list where there are a long list of low probabilities of malignancy on the mammogram, and we could take that list and get the radiologist prepared for a series of those cases. Some cases perhaps might go to a different batch of radiologists. For example, could the general radiologists who is board certified and MQSA certified, perhaps they'll read the low probability cases, and then you leave the high probability cases for the fellowship trained mammographers. There's no real paradigm for this right now. There's no real set of recommendations for this right now. It's just what the practice protocols might want to do. Also, when you triage the cases, and half the list right now has high probability and low probability cases, these cases where the artificial intelligence think that potentially there's breast cancer, these other cases, it may not have a breast cancer. There may be some alacrity to which you might prioritize reading these other cases that are being marked. So the triage function theoretically might speed the diagnosis of breast cancer from a temporal standpoint for the patient and might increase patient satisfaction. So here, as I said, for us, we go to the study date and we just go through the list, and we go through the list as we read through cases. Some of them have a high probability, and you'll see right here as I click the AI triage, you'll see the type of AI we use gives a high score, a 10 for high scored, high probability of cancer in relative terms, and it goes through the list of findings that it's worried about. Then when you get to a case that has a relatively low probability, you see that list of findings go down significantly compared to the other one. And this has a relatively lower probability of having a breast cancer in it, and therefore does not have the triage marker. So in a moment, we'll go through a few cases where we pick this from the list and then analyze and interpret the mammograms. Hello, everybody. Dr. Roger Yang, going through a little bit on breast ultrasound artificial intelligence, trying to introduce the topic. We'll be showing you guys a few cases and going through some of the background. The objectives for today in this short lecture is to explore the efficacy of artificial intelligence applied to breast ultrasound, mostly in the computer-aided diagnosis, differentiating between benign and malignant lesions. Then we have to consider some of the pragmatic approaches and considerations when you use breast ultrasound in breast disease workup. This is a product that we currently use. What we see here right now is a fairly straightforward heterogeneous enlarging mass based upon prior mammograms. And the ultrasound, as we apply the AI product on the lesion, is giving the diagnosis of probably malignant. This is its highest class for this particular AI brand. And this is often helpful in confirming that the radiologist is making the diagnosis aligned with the artificial intelligence. So as you've probably been hearing, and as we've discussed in mammography, the artificial intelligence products usually use deep learning convolutional neural networks. Those have been demonstrated to be excellent in image recognition tasks. The AI is fed lots of annotated images, and then they learn to differentiate between benign and malignant masses. So that's the computer-aided diagnosis part of it. Certainly when you've got the automated breast ultrasound machines that take whole breast ultrasound sweeps and take multiple images of the entire breast, you get it into the computer-aided detection types of artificial intelligence, and those are available. In addition, for breast ultrasound, there are products that look at breast density assessment. They also have predictive and prognostic tools based upon the appearance and what the ultrasound is showing the artificial intelligence. Now, One of the considerations we had discussed in the mammography lectures is that the computer-aided detection is already built into the CPT codes within the mammograms. Now, in ultrasound, this is different. Breast ultrasound has never had a CAD or a CPT code based upon any AI. And so starting in 2022, just a few months ago, there have been new Category 3 CPT codes developed for breast ultrasound. It's a few years away from getting routine reimbursement for these, but practices that deploy breast ultrasound AI can start billing at this point. Obviously, there's a lot of insurance and Medicare and Medicaid considerations with that. But again, at this point with the Category 3 CPT code, there are some financial considerations when it comes to breast ultrasound. So going into some of the data in breast ultrasound or some of the literature that's out there, what was established early on is that the area under the curve and the efficacy and accuracy of breast ultrasound was quite good and actually really helped inexperienced breast ultrasound practitioners. And inexperienced, I don't mean to differentiate between the experienced or inexperienced fellowship trained versus non-fellowship trained, but early on in the doctor's career, as they're analyzing the breast ultrasound lesions, the AI was really helpful getting those less experienced radiologists to come to a higher level of performance, a higher level of accuracy. And so in this study by Chowbey, the ultrasound was detected by the operator. The AI applications applied to the imaging features. They looked at 160 breast ultrasound lesions, and they applied it to 4 radiologists. The least experienced, quote unquote, was 4 months old, so to speak, and the most experienced was 20 years old in terms of practicing with breast ultrasound. And so the sensitivity, the ability to detect the cancers properly or predict the cancers properly amongst radiologists with and without the CAD for the experienced radiologists was not much different, 99 to 99%. As they went down in terms of years of experience, you began to see bumps in sensitivity, 87 to 96% for one rad, 88 to 95% for another rad, and 88 to 91% in another rad after that. And so what we're seeing with the breast ultrasound AI is that it can improve the radiologist's performance, especially with those radiologists with less years of experience. Another study showing a very similar end result, Park et al. They had 3 less experienced rads, 2 experienced rads looking at 100 masses, and this was collected in 2015. The artificial intelligence breast ultrasound product improved the negative predictive value, 87 to 95% for the experienced rads, 54 to 76% in the less experienced rads. So you can see even in this study, even the more experienced radiologists had an improvement in the performance using AI. Overall, in this study, the area under the receiver operator curve improved more dramatically with the less experienced rads. So again, this is a potential huge benefit for the deployment of AI, even with more experienced rads, but certainly with less experienced radiologists. And again, I think that this is something that everybody considers when they begin to look at artificial intelligence overall. Can you help radiologists who are not quite as experienced as others, maybe non-fellowship trained, maybe less years of experience, all of that kind of stuff? It's worthy of a further look as we go forward in the future. And these early returns are showing that this is an area of potential huge improvement that you can apply breast ultrasound AI to, certainly. Here's a lesion, that sometimes could be in the borderline. So for some radiologists, a well-defined lesion like this that's wider than tall, there's cystic components to it. And what's going on in the middle, patients' histories, as we'll discuss a little bit later, factors heavily in breast ultrasound. This is not a static standalone image. There's always a history that we talk about. The technologist is pointing directly to there. So perhaps you've seen this lesion on a mammogram or the patient has a symptom here. So in this case, does a radiologist choose to biopsy or not? And that AI showing that it feels that it's in the suspicious category. But if you look at the upper left corner, this is close to that border zone where this particular product is saying that potentially it goes between the 6-month follow-up and the S suspicious for biopsy. And it's come across, to be suspicious. So in this case, this potentially could help that less experienced radiologist go across a fence and say, okay, well, this is actually something that's actually dangerous to the patient. In this particular case, this is intracystic papillary carcinoma, and the AI was correct. falling on the side of the fence is suspicious. And should a radiologist have waited 6 months for this? Potentially with these more indolent cancers, this may not have changed in 6 months. It might take 12 months to eventually diagnose this. And again, in this particular case, the AI is helping the radiologist make this diagnosis. Overall accuracy has been studied with breast ultrasound AI. The returns on the literature are good that the breast AI improves accuracy of radiologists, and in and of itself is a very accurate tool looking at predictive cancer versus non-cancer. Okay, so Baranov, in this study, 3 radiologists looking at 500 breast ultrasound lesions, they showed that with this particular application, overall accuracy was improved, but there was a particular benefit in terms of reducing the quote-unquote unnecessary benign biopsies, meaning that the positive predictive value of the lesions being sent for biopsies were improved, 7% to 20% in this particular study. So this potentially shows you that breast ultrasound AI could be applied to reduce unnecessary biopsies. Another overall study looking at accuracy and potential improvements to clinical practice. This is Mango et al., 900 breast lesions. And you'll see in this particular study is very interesting. They had 15 physicians and 11 of them were radiologists, but 2 were breast surgeons and 2 were OBGYNs. So when they took a look at the breast ultrasound, and clearly they selected physicians who practice breast health, were used to looking at breast ultrasounds in terms of diagnosis, and they showed that, number one, that the standalone AI sensitivity and specificity compared favorably to all of the physicians, meaning that in terms of accurately predicting cancers, that AI was almost or as good as the doctors who were experienced reading this. And then when you coupled the AI with the readers, there was an overall improvement in the area under the curve. So 14 readers out of 15 had that improvement. Okay, the one reader obviously seemed to not have much of a bump, but the authors speculated that because the AI in this particular case was just newly introduced to the doctors, that the doctors probably were unfamiliar with it. And it's possible that with increased experience and trust in the AI product, that the operators here, these physicians, may all improve over time. Now, again, in this static study at the time with newly introduced AI, they did show that these doctors had some improvement overall. And what they definitely did show also was that inter-observer and intra-observer variability improved with the AI, and that could facilitate more consistent clinical care across their system when applied. So one of the things that the practices that deploy artificial intelligence has to think about is that unlike some of the products in screening mammography, the computer-aided detection and diagnosis products, breast ultrasound often comes with it a lot of clinical considerations and other factors that ultimately affect how the radiologists make a diagnosis and come up with the impression. So we all know that a lot of the breast ultrasound lesions are diagnostic cases. You either already know that something exists there that you're worried about in the mammogram, or the patient has a symptom, or it's a follow-up of something that was previously shown. And at the current time, the AI products look at a static point in time. They look at the image and then they apply the AI to the diagnosis for that static image. The clinician, the radiologist, will often have other clinical considerations. It got larger on a mammogram. It's new. The patient has new symptoms, things like that. So these patients are largely symptomatic in many ways, okay? And so we know that the radiologist has to put in a lot of these clinical factors when it comes into the decision as to whether they'd be willing to follow it or whether or not they should biopsy it, things like that. And I would say that outside the state of Connecticut, where there's breast density laws and screening breast ultrasound laws that require all patients be offered screening breast ultrasound, even in states and in practices where a lot of screening breast ultrasound is performed, some of that stuff, some of those patients are somewhat self-selected. Dense breasts, patients with worry because they have family history, etc. This is not a sort of standard screening population that you're applying breast ultrasound to. So one of the cautions when you look at deploying breast ultrasound in your practice is that whatever the breast ultrasound AI might come with, there are enough clinical factors in it that may still skew the radiologist to biopsy, aspirate, proceduralize lesions that the AI may still call benign. And the radiologist may accept the artificial intelligence answer that perhaps this is something that's going to be benign. But because the lesion has changed, because the patient has symptoms, these are reasons why the AI might help in terms of coming up with a predictive percent diagnosis as to what might be happening after the biopsy. But the radiologist's hand is still forced to call it suspicious and still biopsy. So it's one of the considerations when practices begin to deploy artificial intelligence. It's not a standalone product. At this point in time, in February to March of 2022, autonomous AI, it's probably not ready for prime time, but AI as a supplement to what the radiologists and other clinicians want to get information from the AI to help them make the diagnosis. That's where some of that benefit is at. For example, here we go. This is a new mammographic finding. Looks like a simple cyst to us, but because of the patient's clinical history and because of the patient's preferences, this went to aspiration anyway, despite the fact that it's clearly a BI-RADS2 benign-looking lesion to the radiologist and to the artificial intelligence. In summary, if you deploy artificial intelligence in breast ultrasound, this has the promise to improve diagnostic accuracy, demonstrated in medical literature and in clinical use. This may be of particular benefit in less experienced radiologists. As we all go through the labor shortages that we currently are going through in radiology, potentially redeploying general radiologists, other types of radiologists in breast imaging is something that your practice may be looking at. And deploying AI to help those radiologists get comfortable with the imaging is something that might be interesting. The new doctors that are coming on board that you have to get up to speed, AI might help them get up to speed more quickly than in the past. And of course, this could be a particular benefit in decreasing unnecessary biopsies. If you have people who are worried about lesions and they're on the fence as to whether or not something's suspicious or not suspicious, the artificial intelligence has an accuracy rate that should benefit the radiologist as they develop trust in it to look at it and use it as a supplemental assessment of what that lesion looks like. Also hopeful in the future is that with breast ultrasound AI, that newly developed CPT codes has the benefit of actually paying for the artificial intelligence investment that the practice might have to make. And so this should help speed implementation as things go forward. And that's it for breast ultrasound AI. Thank you very much for your attention. Hi, everybody. Dr. Roger Yang again. And now we're going to go into a topic that signals a shift in how we mammographers were trained to use computer-aided detection. And that's the concurrent use of CAD, or in this case, artificial intelligence, right? So in the past, we used to use computer-aided detection at the end of the exam. We were trained to look at the CAD at the end in order to reduce the bias from the computer while we were interpreting the mammogram. The fear was that we would be using the CAD at the beginning and skimping over things that maybe we would have picked up without the CAD. And unfortunately, and we went through this before in a previous part of the lecture, but unfortunately, that sort of bore out. In 2015, Lehman et al., they found that CAD overall does not improve diagnostic accuracy. And actually, when radiologists who read with and without CAD, they were actually better without CAD. Okay, so without the computer-aided diagnosis, pre-modern artificial intelligence, the CAD, the CAD, actually did not make us better. Similarly, we had talked before about a reader study where they were looking at average sensitivity of a cancer and enriched subset of a small number of mammograms, and their readers were better without CAD. So that early attempt and the mammograms that we read with CAD right now, we have to keep that in mind, that it's on us, the human being, looking at those mammograms, making sure we do not miss anything. Okay, now, as we shift into this current modern mammography artificial intelligence, okay, we are beginning to more and more begin to say, because of the returns on the accuracy, that we're beginning to show that AI is almost and sometimes better than a human radiologist, we're beginning to say that actually we need to read mammography concurrently with the artificial intelligence. All right. So Pasile and others, when they looked at 14 radiologists and another reader study, 240 digital mammography between 2013 and 2016, they showed that the receiver operator curve was improved. The area under the curve was enlarged when they used artificial intelligence. Summary, the AI increase the accuracy for finding breast cancer. Then they showed that when they applied AI during the read, that the reading times decreased when the AI showed there was a low likelihood for cancer. They also did show that when the AI showed there was a high likelihood of cancer, reading times did slightly increase in those things. So they saw a split in terms of efficiency. Makes a little bit of sense. If the AI did not like the mammogram, thought that the radiologist should pay attention to the mammogram, the radiologist did, and the reading times did increase in that subset. Conant et al. In a different reader study published in 2019, they looked at 240 radiologists. That subset of cases they were looking at 260 DBT, okay, and they looked at the mammograms with and without AI, and they looked at it concurrently with the AI. So the humans looked at the mammograms with and without the AI concurrently. The reading times decreased by 52.7%. The radiologist performance improved, the area under the curve increased. Recall rates actually went down from 38% to 31%. Here's that study by Conant. Okay, so we talked about that receiver operator curve again, false positives, trade-offs with total positives, right? So we're over here is the purple dotted line. Those are radiologists without AI. And you can see the improvement and the overall curve shifting upwards, the area under the curve increasing. This shows that the AI was really helping the radiologists find those breast cancers and be accurate. So as a shift from our previous paradigm of bias reduction using the computer at the end of the exam, we are now being taught to concurrently use AI while reading the mammogram. While reading in this way, the radiologists and the AI have the potential benefit of improving radiologist accuracy, okay, while at the same time decreasing reading time. So increasing your efficiency, increasing your accuracy, these are great things for us radiologists and for the practice that we work for and work with, okay? On top of everything else, a lot of outside of radiology cautions of patient anxiety, during mammograms. I mean, it's one of the reasons why, for example, the United States Preventive Services Task Force felt that we needed to do less mammograms, and they recommended that only patients between the ages of 50 and 74 have mammograms, and that we should only do them every other year. A lot of the verbiage around that was talking about reducing patient anxiety. And if we can reduce the recall rates, we can benefit our patients' anxiety. We could also reduce the overall radiation exposure for our patient population since we have to do less mammograms with that. So again, these three benefits of concurrent reading, I think we need to take advantage of them. And as we go forward in the future, I believe that most of us will be reading mammograms with the AI hand in hand rather than at the end. Thank you very much. Hi, everybody. Dr. Roger Yang again. And now we're going to move on to the topic of the installation of mammography AI in your practice. In this particular case for me, I'm in private practice, right? So now we are linked to an academic site, okay, but we have a large private practice, and when we installed AI, we had to really do some research as to what we really wanted, what it was going to do for us, and what kind of flexibility we needed. And so we're going to sort of go through some of those tips as we talk about the available products and how it's suited to your practice. Now, I don't mean to be exhaustive with this. The number of AI products, as you'll see a little bit later in the lecture, is large. Each one of them does something probably slightly different. And of course, the focus on a lot of these things, especially for us rank and file radiologists, is computer-aided detection, meaning we want the AI to help us find those breast cancers, okay? Now, one of the first things that we have to understand is that unlike the installs of the traditional CAD 20 years ago, there is no CPT code and there is no reimbursement for mammography, quote unquote, artificial intelligence at this time, no additional one. Okay, so we'll go through some of this, but the CAD is built into the current mammography CPT codes. Okay. Also, when you begin to look at the available mammography AI, the AI, even if it's just focused on computer-aided detection, they run the gamut of a SaaS or a software as a service, which is a cloud solution that you pay per click with a license fee sometimes it's a per click fee. It's actually a smorgasbord of different things out there when you talk to the vendors about how they want to deploy and how they actually want to charge you. And of course, the integrated solutions where the AI is built into the hardware that you purchase, for example, Hologic comes to mind. They sell excellent mammography equipment, as does all the other vendors, of course. But in Hologic's case, when they sell you their AI, it's built into their gantry, into their workstations, built directly into the hardware. And there's a little bit of a cloud component, but not as much as some of the other vendors. Okay. Now, also, what's good for your practice? What is your practice, right? So if your practice is a one site center using only one vendor and one workstation, one wrist, one EMR, that is a different set of considerations for a practice that is large, maybe multi-state. And again, we're here talking about the United States milieu, but maybe you're multi-state sometimes, but certainly some of these practices are multi-site, multi-vendor, and they have multiple RISs and EMRs. And again, the type of AI that fits into that kind of practice, that can be a challenge for the people charged with operationalizing these to see how it fits into their workflows. We are talking about those CPT codes, and I've lifted this, but I don't particularly have to go through them. So for your billers out there within your practices, certainly the radiologist doing the interpretation, you should be aware of the overall concept of the CPT codes, those codes that we use to bill the insurance companies or Medicare, okay, for the appropriate charges for the screening mammograms. You'll see in those first three lines that those CPT codes already have CAD in them. Okay, so screening mammogram bilateral, including CAD, et cetera, including CAD, right? So those are your actual images, the technical part, and then built into that, the interpretation part of your mammograms. That's how you charge and bill. And you can see it's already lumped with CAD. Now, let's pretend you do not use CAD. Well, you can still charge those codes. It's just that in general, the CAD is now being considered to be built in or not being used. So there is no additional CAD, computer aided detection, and certainly no additional AI fee when you do your install. So the AI is actually sort of on the practice or on the hospital or on the system. It's actually not something that you can currently bill for. Okay. The last two codes, I just want to once again emphasize that with the tomosynthesis, there's actually no CAD consideration for those. Those codes 77063 and G0279, those are tacked on to the first three to indicate that a tomosynthesis exam was being done. And again, to emphasize once again, there currently is no reimbursement for deploying mammography AI. So let's say you've overcome that hurdle and said, okay, well, but there are benefits to our practice. You feel maybe the accuracy benefits would help your patients. Certainly, you might think about some of the efficiency things, decreasing recall rate, decreasing interpretation time, homogenizing different types of reports. So then you go out there and you decide, who am I going to talk to? What vendors am I supposed to look at? And so I very much admire this paper that Van Leeuwen et al. Put out. They tried to corral 100 commercially available AI products that were out there. 12 of these were actually designated in breast imaging. And again, outside of this lecture, we all know that whether it's lung nodules or PEs, liver assessment, all these other things, AI is an active field of study, an active field of advances when it comes to image interpretation. So in mammography, 12 of the 100 in this paper were said, okay, well, that's designated for mammography. Then when you break that down, when you look at the vendors that are in there, you'll find that, yes, there's 7 of these are mammography computer aided detection, but 4 were breast density assessment. Okay, so clearly that is useful, but is it what you were actually looking for? And one of these were ultrasound, breast ultrasound computer aided detection. So once again, this is a mix of different quote unquote AI products that are meant to help your practice, but what is it that your practice is looking for? And then that sort of steers you towards the vendor. Now, you had to remember that this was a nice study showing, okay, well, here's a survey, here's an overview. But here in the States, a lot of these products that are FDA approved and that we have some utility or access to from Hologic, from Lunit, Curemetrics, and Kios, those companies were actually, not named in that trial. And it just sort of, to me, speaks to how rapidly this environment is changing, how quickly FDA approval can be matched, how these companies might morph and go to a certain direction to see what their market and how they can get a competitive advantage over some of their market competitors. So then, even if you've honed in on a few of these products, you and your IT team kind of have to assess what it is that is going to be good for your practice. And we talked about the concept earlier of software as a service. And a lot of vendors, even Microsoft, is beginning to say that, you, the user, buy a license. And sometimes there's also a per click fee on top of the license. And what ends up happening is that the product is there in the cloud. And through an application within your computer system, you can actually utilize a product, have the mammograms go to it, and you're not there trying to maintain it on your hardware. And a lot of the maintenance is happening on their end in the cloud. Some of the things that you have to consider with this is that the more network internet you have to start thinking about, the slower the product might be. Okay, so if it's not housed locally, if you need to send your DICOM images over the net into the cloud down to the vendor then sends it back to you, you're probably talking about 5 or 6 minutes of interpretation time for that mammogram, let alone it's a DBT, right? So if you've got a tomosynthesis study and you've got 800 mammogram images or somewhere thereabouts going up into the cloud, down to the vendor, and then back again, you can imagine the amount of time it might take before you're ready to actually do those interpretations. So your practice may or may not be able to tolerate that. If you offer same-day screening mammogram reads, that might be very difficult. If you're really relying on the CAD product or this AI CAD product to help you with your diagnostic mammograms, you may not be able to tolerate that general concept. Okay, so moving closer to your own network is the concept of the platform as a service. Okay, so the software components and a lot of the licensure is still in the cloud. Okay, you're still sending it over the internet into the vendor, but you yourself, you're managing a lot of aspects of the hardware. Okay, servers, maybe the software product sits on one of your servers, which is closer to your home base. Okay, your gantries, your workstations, things like that. And you're maintaining a lot of those hardware components so that the software can be more efficient. Okay, so you reduce those 5 to 6+ minute turnaround times for AI to be available to your radiologist. Maybe that becomes 2 or 3 minutes. Okay, so then you get into the integrated solutions. All right, now these solutions, I feel they were more traditional in the old CAD because a lot of us used to buy the hardware and the software would kind of come with it. We would buy the license and they would sort of turn it on in the vendor workstation. So what am I talking about? So if you were to purchase a certain vendor and they put in the gantry, they put in their own workstation and your one site, it was very quick and very easy to buy that integrated one-click solution. They would put in your gantry, you put in your workstation, and then we would all read off of that. Okay, so that was very common 20 years ago. And I think a lot of us would identify as, we're a GE site or we're a Hologic site or we're a Siemens site or a Philips site or something like that. And what that denoted is that our acquisition unit that obtained the images, tech and patient, over a infrastructure like an intranet that probably was housed in the same one site, would head over to a workstation where the radiologist was sitting ready to read. Okay, so that's a pretty simple direct shot straight to the radiologist. Okay, but now some of you out there, you might be reading mammography remotely. Okay, maybe you're not reading mammography necessarily remotely, but you're getting multiple mammography from multiple sites. Okay, so what do we mean by that? We all know that there's a consolidation in medicine, a broader topic that not the subject for today. But even if you're an academic center and right in the middle of your territory, you've got a spoke and hub model where you're beginning to acquire or placing imaging centers out there in the community. So you're obtaining images, screening mammograms, et cetera, over a distance. And now your platforms, your network, okay, they become considerations in terms of speed as to how you begin to do this. Then the advantages of an integrated solution begin to diminish, in my opinion, from a financial standpoint. You're going to have to buy a lot of duplicative things in order to mimic that same performance that you had when you had that one site. Okay, so for those of us who identify as a one vendor site, we enjoyed the fact that I sat there at a certain location. There were maybe 3, maybe 1, maybe 10 mammogram units in that quote unquote breast center, and they would take pictures and I would be there sort of monitoring everything. Well, what if some of those mammogram machines were 2, 3 towns away, 10, 50, 100 miles away? So you begin to see that the integrated solutions now have to travel over that distance. So some of that feel of a strong hardware platform begins to diminish because you have to go over a long distance. Also, once you begin to duplicate hardware with integrated software solutions, those costs become a little bit higher than a cloud solution. Okay, I mean, that's why cloud solutions are so popular nowadays, is that when you buy the license and somebody else is maintaining all of that stuff, let's call it, it's less expensive. Okay, whereas if it's you and your team always looking over the switches, the network, the gantry, et cetera, it becomes relatively expensive, let alone the upfront costs of the actual product. So we were talking about that a little bit, right? So let's say you're a one site breast center. I think you have a lot of options out there. You could use the cloud service. Okay, you could take advantage of some of the efficiencies, and especially in terms of finances when it comes to a cloud solution. Okay, so you go with your one product and you've got one vendor for obtaining your images, and then you've got one vendor for your workstation. You have one EMR. And so it's a lot easier for you to not have to juggle a lot of that stuff. The DICOM comes over, you're ready to read, okay? If you begin to have multiple physical locations, that begins to make things more complex. And I think that was the early phases, maybe 15 years ago, when we began to see a lot of consolidation in radiology. You might still have control over your multiple sites. So if you were making this up, General Electric person, radiologist, and you went and you opened another site, okay, maybe in the next town over, you would then buy another General Electric machine. It would feed into your General Electric workstation, and then everything would be hunky-dory there. You're able to integrate things relatively quickly. You still have some options when it comes to, okay, well, I go with the GE AI, or do I go with another vendor that will be in the cloud, okay? Then as we got much more complex, multiple physical locations, multiple vendors for mammography gantries, right? So for example, you're now a Hologic person. Okay, I'll try to mix this around with the vendors. If you like the Hologic machines, okay, you went to multiple physical locations, no big deal if it was all Hologic. But what happens when you buy, or your practice buys an office and it has a General Electric or Philips or Siemens, etc. gantry? Okay, so now you've got two sets of DICOMs. And remember, the mammography DBT in particular DICOM is proprietary. So you're sitting there now with, what do we have? A General Electric workstation, a Hologic workstation, a Siemens workstation, all surrounding you. And what AI works with all three? Okay, and you begin to think about, well, how do I do that? Well, a lot of them have sort of a captive AI. You buy a license and you turn them on in your workstation. So the radiologists, are they in those hardware integrated solutions? Are you really going to learn to use three different AIs just depending upon where the site is? The answer to that for many might still be yes, that's what I'm going to do. And that's fine. You know, that solution, of course, becomes a little bit more complex on your IT end, your operational end, and the finances may or may not be very good with that, because once again, the economies of scale of being able to use one thing and say, I am going to buy a license and I've got 50,000 mammograms that I've got to deal with, you know, splitting it up into 20 here, 20 there, and 10 there, you know, it becomes harder to contract and it begins harder to maintain the service agreements, et cetera, et cetera. So you can see those types of added complexity adds problems to your selection of, well, what happens when you want to install AI? Okay. Probably even more complex is the practices out there that practice in multiple states. Okay, they're trying to maintain one infrastructure. Okay, they might also deal with multiple hospital systems or multiple partners and JVs as their vendors. And so once you get there, you can imagine practices like ours here in New Jersey, where we've got 4 different mammography gantries producing the DICOM images in multiple sites. The settings could be hospital settings with their set of protocols and all the different things you have to consider with that. Private office settings, which are our own, and we have control over those. And then we have private office settings that are joint ventures. So those we have to ask permission. Okay, and more, when you present the economies and finances of, okay, I want to install something, and this could be MRI machines, these could be AI, these could be almost anything. And when you present that, you can imagine a lot of times the people who are making the decisions are saying, look, I need something that is a little bit more cost effective. And the integrated solutions, when you multiply it over multiple of those types of sites and multiple types of buys, it can get very expensive. Okay, the SaaS solutions, you know, begin to be more appealing. Okay, it doesn't mean that they're the best necessarily for your practice, but it is something to consider when you look at those complexity factors. What is it that you're going to do in order to help your patients, to help your radiologists make these computer aided detection for breast cancer benefits with AI. And that's the sort of complexity of how you go through your operational considerations going to this. And again, at the simpler aspect, I think the world is your oyster. Okay, you can sort of look at everything and say, okay, do I want the relatively expensive integrated solutions? Do the relatively inexpensive cloud solutions? What works best? As you get much more complex, it becomes more apparent that you may need to go into something that's more cloud, more flexible, things like that, in order for your practice to be able to offer AI across the enterprise rather than trying to piecemeal everything. As I said before, look at your practice. That complexity, may steer you into flexibility with SaaS or PaaS, the platform as a service. Okay, the simpler the practice, perhaps you're going to be able to do the integrated solutions, which, quite frankly, probably work more quickly, a little bit more simple to install. Once again, become a little bit more expensive, especially as you get more complex. Okay. The conclusion after all this is that, and I'm not trying to make any recommendations on what you're going to do, is that you're going to have to juggle the concept that you're not going to be able to present to your practice, to your chief financial officer, that by placing this new technology, there's going to be a reimbursement increase. Okay, no, there is no reimbursement increase. And you're putting this in for accuracy, for patient care, and potentially for some efficiencies within your practice when you look at AI. Okay, the IT infrastructure has always been important to radiology. And now, especially with AI, becomes even more important. Okay. And again, the larger the practice, the more complex the IT has to be. And you just got to make sure it's there ready to support the AI effort. And especially, as we talked about in previous lectures, to make sure that you keep an eye and monitor your AI to make sure that it's acting as you think it should. Okay. So as you go forward, there's all these different considerations and more to come as we go forward, as the FDA approves even more. And as these products become not just onesies and twosies, do they actually begin to integrate with each other? Does one thing that used to do just CAD, does it go into breast density? All of that kind of stuff is something that you're going to have to keep an eye on when you look at these solutions, and then you'll see what's right for you. Thanks for your attention. Hi, everybody. Dr. Roger Yang again. And now we're going to talk a little bit about mammography, artificial intelligence, and what the papers and literature say out there. I'll present a small section that is of the vast amount of literature that's currently being done on mammography AI in computer-aided diagnosis. Okay, so the first thing we'll do is take a step back in time and talk a little bit about what I'll be terming traditional CAD as we go throughout this lecture series. So computer-aided detection, okay, so for the past 2 decades, probably actually more, radiologists have been using computer-aided diagnosis or detection here in the States, looking at mammograms. And this is your traditional toggle at the end of the mammogram case. You interpret your 4 views. Often this was done on 2D mammogram images. You toggle on and off your CAD images at the end of the exam. And the CAD was meant to and designed to ask that you pay attention to certain areas of the mammogram at the end of the exam, make sure you don't miss those cancers. And again, those CAD programs were more algorithmic. They were sort of computer analyzing the pictures. And if it had a certain margin, it would mark it. If it had calcifications of a certain size and certain number, it would mark it. All these different type of things that were more proscribed rather than deep learning, right? So as we used those programs, we thought, okay, well, this is not bad. It's kind of like the resident or medical student at the end of the attending interpretation saying, hey, how about that area? How about that area, et cetera, et cetera. Now, relatively early on, there were a lot of reader studies being done on that. And, after some initial exuberance with the products, there began to be some cracks in how we began to think about the CAD at the end of the mammogram. So as an example, Alberti in 2004, looking at a reader study of 60 mammograms, and it was a cancer-enriched set of 30 cancers within those 60 mammograms. They had 20 readers interpret those mammograms with CAD, 19 readers interpreted those mammograms without CAD. And they actually found that the average sensitivity in cancer detection with the old-time CAD was lower than without CAD. And the most marked difference in terms of that loss of accuracy was in cases with quote unquote incorrect CAD prompting. And this was actually, somewhat astounding in that actually The CAD did the exact opposite, right? In this case, they felt that if you had the CAD and the CAD told the radiologist there was nothing there, the radiologist kind of agreed with the CAD, and they perhaps were missing the cancers at a higher rate than they really should. Now, this was a small study, and 20 readers, 19 readers, that kind of stuff in a set of 60 mammograms, especially given that it wasn't a real time sort of in vivo study, maybe there was a lot of bias throughout the exam, et cetera, right? So as we went forward, the researchers continued to look at the traditional CAD. And in 2015, Lehman et al. Actually published a large study, retrospective, of course. The mammograms were from 2003 to 2009. And this was as extensive as they could get. I mean, this was an enormous amount of screening mammograms that they looked at, 496,000 or so with CAD, 130,000 or so without CAD. And so these 2D mammograms, looking at multiple sites, 66 facilities, 271 radiologists, and throughout this series, 3,159 breast cancers that were found within 1 year of screening. And they unfortunately sort of showed the same thing that Alberti did, that the CAD did not improve diagnostic accuracy. And in actuality, and by this time, you got to remember in 2003 to 2009, there was pretty much widespread deployment of CAD. And all of us, many of us at least, were using CAD within all of our screening mammograms. And there were a subset of radiologists who had CAD in one section of their practice, no CAD in another section of their practice. And in those radiologists, the sensitivity for picking up breast cancer was decreased when using CAD. So the start of this part of the talk is a little depressing. The computer-aided detection that we thought was actually helping us maybe wasn't helping us. Now we're moving forward into some of the literature regarding this improvement in computer-aided detection with artificial intelligence. Okay, so I'll be presenting some papers using a variety of products. Okay, and so the first one here was another reader study, and this is 240 mammograms, and it's again cancer enriched, 71 cancers, and then 18 radiologists read these with and without artificial intelligence. In this particular case, this is one of the products out of Europe, and that's ScreenPoint Medical Transpera. And when they applied the AI to that cancer-enriched 240,000 tomosynthesis exams, they showed a improvement in their accuracy. Okay, so the AUC, that stands for area under the curve. I think all of us, as we were taught, we understand the receiver operator curve, right? That's that curve that shows that you're kind of giving up false positives and false negatives depending upon where you go on the curve. And raising the curve is actually the goal of any sort of product. We just want to see overall improvement in performance. So the AI in this particular case, when used with the human reader, raised that curve, the accuracy improved. In addition, what they showed was that DBT, well, here in this European study, the digital breast tomosynthesis, the interpretation time went from 41 seconds to 36 seconds when they used the AI. This is Nature magazine, okay, and this is Google, when they applied to some bench research applications with their enormous amount of computing power that they have available, they looked at a set of 2D mammograms. Okay, so this is not tomosynthesis. So this is 2D mammograms obtained between 2012 and 2015 in the United Kingdom, 2001 and 2018 from the US. Okay, and so what they showed is that the AI actually, that it reduced false positives by 5.7% in the US and 1.2% in the UK. You got to remember the United States, as we all know, our recall rates are higher than those in Europe, especially the United Kingdom. But they also showed that false negatives were reduced by 9.4% and 2.7% respectively in the US and UK. And so overall, their conclusion is that Google-based AI algorithm, when applied to interpreting 2D digital mammograms, they're showing that mammography AI actually is outperforming the human reader. Another study, okay, presented, by Watanabe et al. This is with a product called CureMetrics out on the West Coast on 2D mammograms. This is a retrospective study, 122 patients, reader panel of 7 radiologists, okay, and The prior exams were all interpreted as normal, and a traditional CAD had been used during the original interpretation. So the panel of radiologists were able to identify between 25 and 71% of the early cancers with no AI. Then when they used the AI, area under the curve was improved, and the detection was increased to 41% and 76%, depending upon the reader. Also, they began to show that there was less than a 1% false positive recall when using the AI. So this study showed that the AI, when applied even to our false negatives, our misses in the past, that the AI could actually find some of those misses, and they helped those radiologists actually identify and find those misses. Another European study, this one again with Transpara out of ScreenPoint. This was a 7-country multinational study, 28,000 mammograms, 101 radiologists. And so they applied the AI algorithm. They showed that it performed better than 61.4% of the 101 radiologists. Okay, so the conclusion was that the AI platform is comparable to a human reader. There were some human readers better, quote unquote, better than the AI, and the AI was, quote unquote, better than some of the human readers. But once again, it was showing very comparable performance in interpreting all those mammograms. Okay, so in that European screening paradigm, which uses 2 separate human readers, this study felt that perhaps AI might serve as one of the 2 European screening mammogram readers. Okay, so again, a fairly large study with 5 figures worth of mammograms showing that this AI product was actually as good as human readers, and perhaps, now maybe not autonomous, but at least helping the European screening mammogram paradigm be a little bit more efficient by deploying 1 human and the AI rather than 2 human readers. This is that study. And again, you can see it's those 101 radiologists. We talk about that receiver operator curve, right? So you're trading off false positives, false negatives as you go along the curve. And that dotted line shows the AI system in and of itself. And, so in this particular graph and curve, you can begin to see that the AI, the area under this curve, okay, that the AI actually overall performed on average better than the human reader. And again, the conclusion being that, okay, maybe there can be 1 AI and 1 human reading all those European screening mammograms rather than 2 humans. The concept of AI being static is actually incorrect, right? And so often when we deploy these convolutional neural networks, we feed it data, and I probably should say the vendor feeds it data so that is annotated, that is marked as positive or negative, and that AI is learning from the data that it's being fed. And over time, we have to watch, and one has to watch that the AI model does not drift, okay, because there's been shown out there in their basic research in computer science that the AI tools have some brittleness, and they actually have to be checked. There's some degradation of performance over time. So there's a constant improvement process going on with your vendor, something that we all need to be very careful and mindful of when we begin to deploy this, that we ourselves, how we're always checking the false negatives of breast cancers when we do our MQSA reviews, we probably should be checking the AI itself as well, making sure that it is performing as we expect to make sure our human readers are performing. We should always make sure that AI applied to our patient population during those MQSA reviews that we all do, we should check that AI and make sure it's performing to our expectations. Okay. Out of that same ethics of artificial intelligence summary that was given by the ACR and European Joint Society statement, it emphasizes what I just said. Radiologists should use continuous post-implementation monitoring and emphasize transparency as well as protection of patients with respect to their AI. So once you guys employ and deploy that AI, it is our responsibility, especially within the leadership in mammography, to make sure that we keep an eye on it, make sure that it doesn't degrade. So in conclusion, I think that the medical literature in general shows that AI in screening mammography has a lot of promise. It's going to increase accuracy and efficiency. There are multiple ongoing research projects exploring the multiple products that are not available. Some of these products are going to change. For example, some of the vendors, they're currently approved for 2D. They're moving into tomosynthesis, and then they may begin to look at breast density, image, quality, risk assessment, things like that. These are things we all have to keep an eye on and make sure that we ourselves keep an eye on the ball, that we validate the algorithms that they've sold to us, that we ourselves make sure that it's doing what we think it's doing. And thank you very much. Hi, everybody. This is Dr. Roger Yang out of New Jersey University Radiology Group. And over this lecture series, I'll be talking about breast imaging or mammography, artificial intelligence. And what we're going to do here as we get to our course objectives over the next few lectures, we're going to review some pragmatic practice-based concepts of the efficacy and use of mammography artificial intelligence. In our particular case, it's in the private practice setting. We're going to identify key considerations when selecting a mammography AI product. We're going to compare the effectiveness between the traditional CAD or computer-aided detection models that we've all been using for the past 2 decades here in the States. We're going to compare those with the current convolutional neural network models for mammography image analysis. We're going to review the benefits of concurrent use of artificial intelligence for mammography interpretation. So I've presented to you here an anonymized DBT study, C-view on it's on the right-hand side, but that's the left MLO view, and it's the tomo view on the left-hand side, that's the right MLO view. And you can see that blue mark, which a lot of us are used to when it comes to computer-aided detection, but behind that blue mark, and you'll see, again, be seeing this a lot as we go through the case presentations, behind the blue mark is actually now what we call artificial intelligence. All right, so now the broader field of artificial intelligence when it comes to computer science, it's that computer algorithm or computer platform that emulates intelligent human behavior. There are some underlying types of AI especially applicable to image analysis and mammography. So that first level is machine learning. Computers will learn from data without being programmed with algorithms. The computers might be supervised, they may be unsupervised, or that is, they may be based upon continuous reinforcement with ground truth, with annotated images to show the computer what they should be looking for as they go through its interpretation. When you use multiple layers of machine learning, they start calling that deep learning. So those computer networks with multiple layers pointing towards the same problem is that deep learning, and you've probably read about that a lot. And even further, when you've got multiple layers of deep learning systems, they call those convolutional neural networks. And this has been especially useful in image interpretation, image recognition, and so very applicable to our field of radiology, and in this particular case, in mammography. So yet on another level, when we talk about AI use in mammography, many of us rank and file radiologists think about computer-aided detection. We are interpreting mammograms. We want to see whether or not the computer can help us find those breast cancers. So computer-aided detection might be at the forefront of the clinical radiologist concepts of what AI or artificial intelligence can help us with in mammography. Now, we should be aware that a lot of AI platforms are actually currently being applied for things like breast density assessment. As we know, there are a lot of studies out there showing that even amongst the same user, there are some disparities in breast density assessment, A through D, 1 to 4, or fatty to very dense breast tissue, that human beings have a lot of variability depending upon the setting, what they're doing, what the prior mammogram showed, things like that. So breast density assessment, when it comes to a computer actually measuring the amount of breast density, and especially when AI is being used to help with that assessment, that's going to be more consistent. And particularly in cases where we're using breast density to make other recommendations, it might be more effective, more accurate, things like that. Image quality assessment, when every year we go through these ACR and MQSA inspections for us to show that our technologists are obtaining really good quality images. Now, the AI can monitor all of those images as they're being obtained. And so that image quality assessment with AI use can help our technologists get good mammograms, reduce quality, reduce recalls for quality, things like that. And again, AI is in the background on some of these programs doing that for us, should we want. Breast cancer risk assessment. So this is another hot topic for us. We are beginning to more and more talk about individual patient-oriented recommendations for screening. And so part of that is that breast cancer risk assessment. So AI, looking at some of the clinical data, looking at the image and incorporating it with the clinical data, might be able to come up with good recommendations going in the future. And so the next bullet talks about that a little bit, but probably goes even further. The artificial intelligence may take the image, make an interpretation, and they may even go further to talk about proper therapy for things that it might see and begin to talk about prognosis based upon data, based upon what it's seeing on the mammogram images. Now, there's no one commercially available product that are doing all of these things put together, or at least not yet. And so most of the products that you're going to see when you go to one of the big trade shows, or when you call somebody to talk to them about getting quote unquote AI in breast imaging, they're going to do maybe one or two of these functions, but a lot of these AI companies are really focused on the one thing that they're doing well. And even further, especially with some of the things that we're about to talk about, you'll see that in computer aided detection, AI sometimes will be good for 2D mammography, but have not yet been approved or have not even approached tomosynthesis just yet. So when you go talk to your vendors, you got to ask them the questions about what exactly is their AI product doing, whether or not it works in your particular environment, and whether or not, again, is it FDA approved in 2D and tomosynthesis and all the other things that we were talking about over here. So here in February of 2022, we have to acknowledge that in this field, in this artificial intelligence in radiology and in particular mammography, this is an active area of FDA approvals and research. The climate is changing, and a good example is some of the myth busting that we have to do in the news, right? So this isn't research that I'm presenting here. I'm just showing you how what's presented out there seems like artificial intelligence is this upcoming problem for us human readers. It may be a problem for radiologists. So some of the headlines we actually have to deal with, out of the Washington Post in December 2021, just relatively recently, there's this concept, this title of "Is artificial intelligence about to transform the mammogram?" So what does that actually mean? It's a vague enough title, but it's just talking about a change in how we radiologists might practice. And of course, physicians, we are used to change, but we don't necessarily like it. So what does that actually mean? What is the lay press and what are our patients reading about? And in this particular case, this is really just talking about AI being used to help predict future risk for our patients in mammography. It's not particularly threatening to us. Obviously, when it comes to radiologists in particular, we're not going to be replaced by a AI that's really just taking the mammogram and just determining whether or not the patient has a better, worse, average risk to other patients, within our program. An even more threatening concept here is Google, a big, huge multinational company that all of us use to do search on the internet. It's talking about Google replacing doctors. Okay, so now when we see headlines like this, now radiologists begin to feel very threatened. And Google, in general, did some good bench research with this, took their very powerful servers, applied it to 2D mammography reading, and they did find that AI had some benefits when it came to looking at those mammograms. We're approaching the efficacy, the accuracy of human readers. But we have to be quick to point out that this is not an FDA approved product. And Google has actually currently, and I don't know about the future, but here in 2022, there is no actual product that they're putting out there, and they have nothing available to be purchased by a health system or a hospital or even a radiology group to actually change and replace doctors just because, quote unquote, it bested doctors in detecting breast cancer in mammograms. How about our attitudes? And obviously, I alluded to the fact that, especially when we talk about radiologists practicing and reading mammograms, that we feel a little bit threatened, okay? And this probably comes out in some of the surveys that we put out there. So the American College of Radiology, one of the big national organizations that represents radiologists, they put out a survey here in 2020 is when they actually published reports. They talked about radiologists using AI. And in the subset of radiologists who are actually using AI, 93% of those radiologists said the AI results are inconsistent, actually. And that 95% of the radiologists said they would not use AI algorithms without a human physician overread. Okay, so There was a lot of recommendations that came out of this, including that the FDA really should begin to think about changing its approval and maybe adding some sort of maintenance process so that we can make sure that post-market, the product that's being approved and any of the changes in the algorithms, they will continue to function as expected in over the long term. Okay, so one of the things that we'll also be talking about in the future is the responsibilities of the radiologists and the human designers of the AI, and how they do have to make sure that what they first put out there continues to meet performance standards as things going forward. Now, the conclusion of a lot of these things is that there's really no indication that here or even in the near future that AI will be ready for autonomous use. Okay, so most of the things that you're going to see in the literature, and the vendors certainly, they themselves really believe that the physician has the responsibility and there's no replacement of the human reader. How about our patients? Okay, and so one of the few studies that actually studied in mammography in particular and breast cancer screening, one of the few studies that looked at how are our patients receiving what they're reading in the news and what they think about computers looking at the mammograms. This was in the Netherlands, right? So what we have here is 922 Dutch women, and they were aged 16 to 75. So after looking at a lot of demographics, what they thought about AI, they showed that 78% of our patients, or these patients here in Europe, they believe that a human should read the mammogram. Okay, so the widespread acceptance of saying, okay, well, AI is good and they really should replace the human reader, our patients don't seem to be ready for that, or at least that's what this study suggests. 42% of them disagreed that AI should be used to select which screening mammograms get a human read. Okay, so what does that mean a little bit? So a little bit of background. I know the audience here, some of you may be from Europe or from countries and places outside of the United States. In the United States, we are very used to single readers in our screening programs, one radiologist for one mammogram. And in Europe, it is much more commonplace throughout Europe, where they've got a double screening mammography program, meaning two human radiologists will actually read those screening mammograms. So here in this study, 42% disagreed that the AI should be used to select which mammograms get a human read, meaning they don't want any of the AI to be autonomous. Okay, now 25% also disagreed that the AI should be used as a second reader in the European two-reader screening protocol. So what does that mean? They believe that 25%, 1 in 4 women, believe that there should be two human beings reading those mammograms as protocoled in Europe. We talked a little bit about those artificial intelligence ethical considerations. And this topic was so important that the American College of Radiology and the European Multi-Society Statement on the Ethics of AI, as published in October of 2019, they emphasized a large number of points. And some of the highlights that I want to give here is to talk about the concept that the AI, that accountability and responsibility for patient care while utilizing AI, it rests with the practitioner, that's us, the radiologist, and as well with the human designers of the AI platforms, and that's our vendors. Okay, so there's some accountability that has to be taken by all of those parties to make sure that we are ensuring that patient care is at a high level. All right, now we also should be deploying AI in order to promote well-being, minimize harm, and ensure that the benefits and harms are distributed among the possible stakeholders in a just manner. So, for example, perhaps practices that install AI, we should not be charging our patients for the AI, not for the benefit. We put it in and we apply it to everybody. Also, perhaps practice that install AI, we should not try to install AI only in one part of our practice. Obviously there are operational considerations, some of which we will get into later in this lecture series, but we shouldn't think about, okay, well, certain places within our practice, maybe they should have the AI and other places don't need it. Okay, and that kind of concept is probably not something we should deploy if we can help it. A lot of times when we do a lot of these things, these are expensive installs, and maybe we think about, okay, we'll do it where maybe it makes some economic sense. And again, these are perhaps things we need to avoid. There are a lot of unintended consequences when we deploy these AI programs and protocols, and again, probably something that we need to avoid. We should make sure that we distribute the AI in a even and just manner. So in summary, mammography artificial intelligence. It's here to stay, and it does have many beneficial uses. And we just have to be careful when we talk to our vendors what it is that they're actually offering us, what their AI is going to be actually doing. You have to have some careful ethical and operational considerations when you implement your AI in your practice. In 2022, we are not yet ready for autonomous AI. There's always going to be human reader here in 2022 when we implement the AI. What happens in the future, I personally believe that there will always be some human responsibility as these programs get better. And again, I just don't know that our patients, as you saw from those surveys, I don't know that our patients would accept the concept that there are no human beings reading their, in this case, mammography images. So in the upcoming videos, we will explore more mammography AI effectiveness, operationalization, and then some interpretation tips as we go forward into case review. Thank you very much.